little bit of background on myself. So when ABM got started, we really started the business, my wife and I, with National Institute of Health grant funding. And I've been the principal investigator for a little over $8 million in NIH grants. And as my career takes me around, I'll be starting to submit again this fall for a couple of, to fund some studies for validation of some new biomarkers. So over the course of my career, I published over 40 peer-reviewed papers, invented over 20 products. We now, through the FDA and Health Canada, have a number of cleared devices. Some have been retired or sold off. We have 6 active products that are currently up in Canada. Very recently, just last month, we reported the discovery of a novel EEG biomarker that we call non-REM sleep with hypertonia that looks like it's associated with alpha-synuclein-related neurodegenerative disease. And that's we have a paper right now submitted to the journal Sleep that describes that and compares it to a number across different alpha-synuclein-related as well as beta amyloid or tau neurodegenerative diseases. And I've been recognized by my research by the American Academy of Dental Sleep Medicine over the past couple years. So first, let's do the literature review on the night shift. This was a paper I was first author on a couple years ago, and it really evolved from the initial validation of night shift where the Cartwright formula, most people are trained that if you take the supine AHI and you divide it by the non-supine AHI, and if the supine is at least twice as severe, then that's how they define positional obstructive sleep apnea. When we went to the FDA to get clearance for the night shift, they were absolutely, what mandated was I needed to be able to demonstrate a 50% reduction in the overall AHI. And I was very concerned because that supine divided by non-supine isn't always the best measure of whether or not that person is going to get an important reduction. So in going through the data and working in Excel, I came up with this alternative where if you take the overall AHI and divide it by the non-supine, you end up getting an alternative ratio that I'll show you in a minute that actually is better at predicting who's going to have an important outcome. Well, you can see here that what we call the Rose-Cartwright, or the supine divided by non-supine, compared to what we had developed the overall, the correlations are quite high, both at a 3% desaturation and a 4%. But then when you test them and say that if I say that somebody has positional sleep apnea, how often will that classification result in at least a 30% reduction in the overall AHI if they stay off their back? So with the supine divided by non-supine and at a 3% desaturation, what we presented in this paper is that you would result in having false positives. That is, patients will be identified with positional sleep apnea, but you will not achieve a 30% reduction by keeping them off their back. And it also led to 3% false negatives in that it says that they don't have positional sleep apnea, whereby if you just kept them off their back, you would see a 30% reduction. And this is at the 3% desat. You can see the overall by non-supine is far superior in being able, if the goal is to be able to say, I want to identify those people that if I keep them off their back, I'll see an important reduction in the overall AHI. Now, this was the paper that we published in the Journal of Clinical Sleep Medicine back in 2014. And this was this was the validation of the night shift. And what I found interesting here, most people talk about positional sleep apnea being for mild and moderate. And what I did that was kind of novel at the time was I said, well, maybe there's something about those severe people that there's something there. And so rather than just throwing everybody about 30 events per hour in the same bucket, we stratified it into those that were between 30 and 60 and those that were over 60. And what you see here, this is the percentage of patients across the 3 main severity groups that have, according to the overall divided by non-supine, have positional sleep apnea. Now, the ones in blue are those that would have a non-supine AHI less than 20, which is a criteria that the FDA established for clearance of our device. But you see a large number of patients have positional sleep apnea who are severe. They're just not going to go all the way down into the normal range. So the important point here is almost 75% of patients in the mild, moderate, and severe, but not very severe range have a positional influence. So that means that they're likely going to be better candidates for oral appliance therapy, that if you kept them off their back, it would probably reduce CPAP pressures and so on. A good colleague of mine also recently reported he looked at the prevalence of positional obstructive sleep apnea in patients looking out many years after they came into the lab, and found that 70% of the patients remain POSA after almost 7 years. So it doesn't happen in all the cases, but it does suggest that at least in those younger patients, that if they start out with positional sleep apnea, a large portion of them will remain so for quite a period of time, at least for the length of what, for example, the night shift has a 5-year useful life, which means the vast majority of them will remain positional obstructive sleep apnea during the life of the device. Now, these are the results from our study where we had 30 patients. They came in, did polysomnography, they wore the night shift for 28 days, and then we did a follow-up test, and it's all to be expected. The supine AHIs went way down, non-supine AHIs didn't move much. And the point that I'm making in this slide that I found interesting was, and what I was curious about was whether the non-supine AHI pre and post treatment after a month, is it stable or not? And so what you're seeing here, the yellow means that they were relatively stable across the 3 severity groups. Red means that they got worse by more than 5 events per hour. And green shows that they improved by more 5 events per hour. And the take-home message from this slide is that patients with mild to moderate OSA, their non-supine AHIs stay about where they started. But those patients that are severe, the vast majority of those end up with non-supine AHIs much lower than when they started. So the point is that if you're looking at a study and you're deciding, is this person a good candidate, especially a severe one, and you're looking at that non-supine AHI, if they're severe, you can expect that that's going to come down a little bit. Now, the other part of our study that was interesting, we showed or demonstrated that this was one of the first therapies that actually showed improvements in sleep architecture as a result of therapy. So you can see the arousal index was significantly lower after 30 days of therapy with the night shift. Now, just as a little side story, I had submitted a grant to the National Institute of Health to fund the development of night shift. And one of the reviewers on it said, this won't work. All you're going to do is vibrate and wake everybody up. So the study got rejected. We funded it internally instead. But you can see both arousals and awakenings significantly reduced. The amount of N1 sleep significantly reduced. N2 went up. And REM was close to significant. So this product or this device improves the architecture. What surprised us a little bit was it didn't convert to substantial changes in the self-report. So you can see, well, depression, the PHQ-9 decreased or increased, which is a positive, but the Epworth Sleepiness Score did not really significantly change, nor did the Insomnia Severity Index. So this is just an indication that that patients, while the overall AHI, those sleep disorder breathing and sleep architecture improved, their self-reported scores didn't. We also conducted a study where we were looking, this were patients who were It was either 15 to 52 weeks using the night shift. Now, I want to qualify this study is that this was not a prospective study. This was retrospective. These were people who were using our compliance portal. So we have to assume, first of all, that they were motivated with the device to want to go in and generate a report. So it skews a little bit of the compliance data, and that's why I pushed this down at the bottom. But the more interesting take-home messages from this study was the first one, that there was a concern that if you give somebody vibrotactile feedback, will they begin to ignore it over time to where they habituate to the stimulus? Now, what this would indicate was over time, it would cause, you would need more and more vibrations for them to get off their back. And we simply didn't see it. We actually saw that over time, they responded a little quicker to the feedback as opposed to ignoring it. There was also a question of whether or not if somebody uses the device, can they get trained to not sleep on their back so that they won't need to wear the therapy long term? And that, again, was another fallacy that we demonstrated, in that while the average person attempts to go on their back 7 times a night and over up to 52 weeks of therapy, on average, it went down to about 5 times a night, but it never went to 0 for anybody that wore the product. So if there was somebody that didn't, if they only typically went on their back 3 times a night, it would go down to 2. If it was 13 times a night, it'd go down to 11 or 12, something like that. We also saw that, the vast majority of patients who were non-compliant, that weren't using it every night during the first 12 weeks, were non-compliant long-term. So much like CPAP, having an intervention and being able to communicate with the patient and make sure they're using the therapy, important part of achieving long-term compliance. Now, this is the first independent study of ours, and this is where it was a study where they compared night shift to CPAP. And this study was conducted in Singapore. And so they were all Chinese patients. They all had positional obstructive sleep apnea. It was designed to where the patients were randomized to where either they wore CPAP first for 8 weeks, then a 1-week washout, and then position therapy, the night shift, or the alternative, they started out with position therapy, the washout, and then CPAP. And as you would expect, the AHI with CPAP was significantly less than position therapy. The amount of N3 sleep with CPAP was slightly greater. That surprised us a little bit because we've seen generally the sleep tend to go deeper. We saw that the arousal index, that patients were more aroused when wearing CPAP than with position therapy, but we didn't see the change in the Epworth score. And so their conclusion from the study was that position therapy was inferior to CPAP because the difference in Epworth scores as a result of 8 weeks of therapy was greater than 1.5, and ours on average was 2. And that was the predetermined threshold they had established for inferiority. Now, one of the things that surprised me, 2 things that surprised me. First of all, they found that 60% of the patients preferred CPAP and only 20% preferred the position therapy. But to me, this is a very telling piece of information. What we're looking at is the first arm here, and these are hours of use of CPAP, and then hours of use of position therapy. And here's where they started with the position therapy, and after the washout, went to CPAP, and you can see that those patients that started with position therapy, that their CPAP compliance was much, much lower. Now, these data don't make a lot of sense, but it did point me to one fact, that these patients all had about an hour of mask fitting and CPAP education before they started the CPAP. But with position therapy, they essentially handed them the device and said, go start wearing it. So I believe that helping the patient understand how the position therapy works, what to expect from it, could have improved some of these preferences and potentially some of the outcomes that we saw. In both cases, the utilization wasn't as great as you would hope for. Now, this is a study of patients who were prescribed and sold night shifts in Italy. This study came out late last year in the Journal of Clinical Sleep Medicine. They looked at 84 patients that had POSA. They did a PSG after 6 months, brought them back into the lab, and you can see that the position therapy reduced the AHI. This was across a broad range of mild, moderate, severe. In a little over half of the patient, it reduced the AHI, but by at least 50%. They did use the Cartwright formula rather than the overall divided by non-supine that may have influenced this a little bit. One of the factors they found was that over 22% of the patients had a normal AHI in the non-supine position. Now, this number is important because I'll bring you back to it with some of the other research that we've seen. And finally, as expected, the night shift kept them off their back across all severity ranges. Now, here again, we don't see the results as that promising in that only 42% of the people were regularly using the device at 6 months. What is kind of fascinating is the vast majority of those that had moderate OSA were using it, and the vast majority of those that dropped away had mild sleep apnea, suggesting that those with the moderate OSA were feeling the benefits of the position therapy and therefore kept using it. Now, here are the list of reasons that the patients gave for why they discontinued use. And here is one where I did not know they did the study. I had not, while my distributor in Italy is aware of the features, we don't know what was communicated to the hospital to communicate on to the patients. But for example, 2/3 of them found it difficult to fall asleep wearing the night shift. Now, the night shift automatically delays feedback for the first 15 minutes to allow the patient time to fall asleep. We don't know if they were instructed to turn it on right at lights out or not. We don't know if they were notified that they could shift the vibration start time to a full 30 minutes. So we do provide that option to delay the feedback further, but we don't know what the patient was instructed in the study. They also said over almost 2/3 felt that they were awakened by the vibration. Now, again, we felt this is part of the education process in that almost all patients complain that the device caused them to awaken. And when we go back and look, we ask the patient the question, well, how often did this happen? And they'll say, oh, 1 or 2 times a night, typically during the night. And we'll look at how many times the device actually moved them off their back. And there's a fairly wide discrepancy between the two. So in talking to patients and looking at some of the other sleep studies when this is ongoing, what we believe is happening is these patients are finishing a sleep cycle, they move on to their back, they're already kind of in an aroused state, they go onto their back, the device vibrates, and they said, it woke me up. So the important thing here is to educate the patients that the device is going to vibrate, that they're going to be in a lighter stage of sleep, and it's typically it's a point in time where they might change positions, and that could cause them to recognize this. And if they believe it's happening, show them the report or explain how to look at the report and count the number of red lines in the report, which is the number of times that they attempted to go on their back, and match that up with the number of times they thought the device caused them to awaken. And we're fairly confident there's going to be a discrepancy. Now, in this group, they also, a third claimed to have back or neck pain. And again, this is something that we're seeing more and more and making recommendations. I know myself as somebody who's a side sleeper, my comfort was greatly improved by being able to get a side sleeping pillow. It's very important to align the spine. And also, there are a lot of people have mattresses that are comfortable for supine sleep, very firm, that don't work as well for side sleeping. So we've done some work on the internet, and a side sleeping pillow and a mattress topper costs about $200. But that is definitely a way for patients to dramatically reduce this complaint. Another third complained about the neck strap discomfort. And we've seen this multiple times. It happens more often in women just because they're not as used to wearing something that's around their neck. And I'll be explaining or showing you in a little while that we now have a chest band, a way to wear the night shift either on the chest or the neck. So this is another development that we've made to overcome this objection. The one that startled us or surprised us a little bit was this low battery charge. What this would be because of is that the USB charging cable wasn't working. But again, education, working with our distributor, that should not have been a problem at all. If the battery is low, it gives a blinking yellow light. They should have recognized that. And even in our instructions, we say, you know, just plug it in with any micro B charger, and it'll should have fixed the problem. The last problem that they experienced was a vibration disturbing the bed partner. This was only 14%. Now, if you go and look at the Night Balance, which is Philips' device, this number was much, much greater and was the primary reason why patients chose not to buy the Night Balance. So we think this is pointing to vibrating at the neck, where there's a lot of vibrotactile receptors versus vibrating into the chest over adipose tissue, so that getting that information communicating up to the brain to get off of the back, I believe, isn't as effective when worn at the chest. This study has just been published. It's in press. It is a study where the patients came in and they randomly assigned them to either night shift or to oral appliance therapy. So they had 160 patients, 80 patients in each arm. And after 8 weeks of therapy with the night shift, they brought them back in for a follow-up PSG. With the oral appliance, it took about 8 weeks for them to get the oral appliance through its final adjustments. And if it took a little bit longer to finish up with those adjustments, then their follow-up PSG was a little bit longer than 8 weeks. Now, what's a little bit different about this study is they did not select patients with POSA. These were all patients diagnosed with sleep apnea. So that would explain some degree why the AHI post-treatment with the position therapy was close to severe compared to the oral appliance. We can see that the device worked great. It kept people off their back, although in their study, they did report 5 people who just didn't respond to the therapy at all. And this, if you look at the report, what it means is that red line I referred to earlier becomes a big, long red bar, and that means the vibration is going off for a long period of time. And while we have worked to improve the patterns to reduce the occurrence, there are some people that just sleep through the therapy. And we've had cases where people have come back and said, yeah, I had a dream where, the dream had kind of worked this whole vibration into what was going on. And that was why I didn't move off my back. Now, these results are looking at those patients who were responders. So we're looking at, in this case, where the pre-treatment AHI, post-treatment AHI, while they were close to significant, all we're seeing here is a slight greater variability in the standard deviation that made this significant. But the important thing, and the reason I'm pointing this out, is that the position therapy once again improved sleep architecture. They showed a significant reduction in spontaneous arousals and improvement in M3 sleep that they did not see with the oral appliance. So this is, again, the second study that has showed that the night shift actually does improve sleep architecture, sleep continuity, and that possibly some of the patient concerns about it, quote unquote, waking them up, is more about patient education than physiology. Now, the next I'm going to do is briefly go through some new data that is currently in press. Well, it's being reviewed. I will know within the next day or two whether or not it's been finally accepted. But this is a study of 170 patients, CPAP intolerant. They were fitted with our ApneaGuard trial appliance. I'll explain a little bit more about that in a minute. But it's so with the apnea guard, they underwent a 2-night study. The first night was baseline. Night 2, they wore the apnea guard. And then we used this data to look at a cost-benefit analysis, trying to identify when it would be more appropriate for oral appliance therapy or when it would be more appropriate for supine avoidance therapy. And for this analysis, the oral appliance therapy responder criteria required either a 50% reduction in AHI or the pre-treatment AHI was greater than 10 and then less than 10. And one of the first things we did is we looked to see, did positional obstructive sleep apnea impact oral appliance outcomes as far as responders and non-responders? And you can see, yes, a greater percentage of oral appliance therapy responders had positional sleep apnea, and this was based on the 3% criteria. Now, back in 2010, we were the first to report the interaction between positional obstructive sleep apnea and OAT responders. And back then, with the 4% response, you can see that the portion that we had with POSA was 93% compared to 53%. But in both studies, what we're saying is if they have positional obstructive sleep apnea, they're likely to have a better outcome with oral appliance therapy. When we also looked at when you think about who would be POSA and who would not be POSA, obviously the non-supine HI comes into play here. So what we see is those patients who were non-responders with the apnea guard had significantly elevated non-supine AHIs compared to the responders. So at least what we believe to be true is as that non-supine AHI creeps up, they're not only going to be not appropriate for position therapy, but it's also less likely to have a successful outcome with oral appliance therapy. When I say less successful, what I mean is it's not going to be below 10. That doesn't mean that they're not going to have an important reduction. But again, when we think of the patients who are really severe, we can get a 50, 60, 70% reduction, and they still may end up with an overall AHI of 20. We also looked at, this was kind of a comparison, what we were curious about. We had seen previously differences between men and women. Others have reported this in some of the dental literature, that men overall were more severe than women. And here we can see in the supine AHI, pre-treatment, the men were significantly greater than women, and that did not change. They were still significantly greater post-treatment. And because men have longer airways than women, we believe that what this means is that airway length, the longer the airway, the more readily it's going to collapse when they're in the supine position. And then when we look at the non-supine AHI, again, men started out with greater non-supine AHIs than women, but then after treatment with the oral appliance, there were not significant differences. So this does suggest that how patients, males and females, change as a result of oral appliance therapy by position, it's impacted and it's different. Now, the other thing we found in this group of 170 patients, they're all intolerant of CPAP, is that 20% of them had a non-supine AHI less than 5. So in the study out of Italy, we saw that it was 22.5. There was a study that was just published with over 1,500 patients in France, and they also found 20%. So, this number looks like across the world, it seems to be holding up pretty well as what you might expect in patients who are intolerant of CPAP. Now, the last analysis that we did was we were curious about when it would be appropriate to combine supine avoidance therapy with oral appliance therapy. And so when we looked at the cohort that I described previously, and we separate those into responders and non-responders. So here we see the green is the pre-treatment AHI of those responded to oral appliance therapy. So they move from this green bar down to this green bar, and it was significantly different. The non-responders, you can see they hardly moved at all. And there were obviously significant differences post-treatment with responders and non-responders. But if we combine the oral appliance and then look at what the non-supine AHI is, with the oral appliance and use that as a surrogate for position therapy, you can see that you can significantly, and now these were patients, let me back up. These were patients that had an HI with the oral appliance greater than 10 with residual POSA. So we're looking at patients looking at post-oral appliance therapy that had residual POSA. So therefore, you can see that by potentially adding supine avoidance therapy, you would get a further improvement with the oral appliance. And what's most interesting is these non-responders with the combination of the oral appliance with supine avoidance, they almost normalize, they become equivalent to the oral appliance responders. So this does point to look for the post-OAT AHI and look to see if there's POSA, and they would be good candidates for the combination therapy. Now, this is an area, a little bit of a passion of mine, a little early in the game. I'm always accused of being a little bit too early in some of the areas that I'm interested in. But we have a large National Institute of Aging grant, and the goal of that grant was to look at waking state EEG and sleep EEG markers in order to identify and differentiate different types of neurodegenerative disease. And when we had a fairly small data set at that point, we had 45 patients with neurodegenerative disease, and we started doing some discriminant function analysis, some machine learning algorithms. And the most predictive variable between the two groups was that those patients with neurodegenerative disease slept more than 2 hours a night supine. And I said, oh, I can't believe this. This is so interesting. And so we ended up putting together a paper and drew an additional 120 controls from a group at Washington University who were using the sleep profiler to do investigations of patients with Alzheimer's disease. And when we looked at all this, what we found is that the odds ratio of those patients who slept more than 2 hours per night, the odds of them being in the neurodegenerative disease group was 3.7. The reviewers, prior to getting accepted by the Journal of Alzheimer's Disease, wanted to see if maybe this was just a factor that patients with neurodegenerative disease just don't change positions as much. And you can see that when we went back and counted the number of position changes an hour, there was really no difference between the two groups. And then finally, we did a multivariate logistic regression analysis, and we'll be able to demonstrate that this finding of the supine sleep time and its association with neurodegenerative disease was independent of sleep apnea, age, gender, and snoring. So it was the first to report this association. But we also had, in the discussion, we also linked it to other findings in that it's pretty well known that sleep opens the pathways for glymphatic clearance of neurotoxins, and that occurs primarily during sleep. A study by Lee and colleagues, right now the only way that you can even image the glymphatic system is imaging on rats. We can't do it on humans yet. But when they looked at anesthetized rats and used the anesthesia as a surrogate for sleep, what they found was that the lymphatic clearance was less effective when those rats' brains were supine versus lateral left and lateral right. And there also was some research in this that showed that the inspiration and expiration were the primary regulators of the cerebral spinal fluid movement in and out of the brain. Now, many years ago, back 2009, 2010, I had developed an algorithm for using forehead venous pressure as a measure of respiratory effort. And we also saw that signal would be affected. It wouldn't be nearly as strong in the supine position. So we know that gravity was playing a role in this. And shortly after our paper came out, it was very fascinating. A group in Poland published this paper where they were using sonography to look at and they were doing imaging of the jugular vein. And so what we see here, this is the left internal jugular. This is when they're lateral left. And so what they're saying is when you're lateral left, you end up where the left internal jugular is below the heart. Therefore, the internal jugular on the left side should be open, and the right side that's above the heart should be partially closed. And the opposite occurs in the lateral right position. But when they did some imaging of patients who had abnormal internal jugular valves, they were open all the time, whether they were lateral left or lateral right. Also, when they did the imaging of patients, these patients in the supine position, what they saw was both internal jugulars were open in the supine position. And so their hypothesis is that partial closure of that internal jugular that is above the heart during sleep creates flow resistance that optimizes glymphatic clearance, and that doesn't occur in the supine position. So we're a ways away from being able to, do a cause and effect or anything close to that. But I do find it kind of interesting research and something that we hope others will follow on with. And lastly, that same 170 patients I've been talking to you about, the point of this slide is simply to say, if we look at all these patients and how many of them slept less than 2 hours on their back one night versus 2 hours the next night, only 12% of the patients were staying off their back for more than 2 hours. So the proportion of patients out there, in this case, these were patients were CPAP failures, a vast majority are spending a fair amount of time on their back that might maybe long-term benefit them to not do so. So I'm almost done here. This is the last part, and I just want to introduce you to a couple new features I had mentioned earlier. You're familiar with the night shift on the neck. We now have night shift on the chest as well, and so it does require, it's the same device. You do need to go on to the portal and flip the setting from neck to chest, because all we're really doing is setting the recognition of supine 180 degrees. You may or may not be familiar. I don't recall talking through the staff there and talking about all the features of the night shift, but I know that a number of dentists use this as, with feedback off, they want to use it as an assessment because it has an acoustic microphone, because the sleep wake that we measure by actigraphy is about twice as accurate as what you get from a Fitbit or any of those. And because we're measuring position, that some people are using this in what we call the feedback off mode in order to look at oral appliance titrations. And then with the therapy on, then you start being able to see how many times did they attempt to go supine, what was the typical response, meaning how many times did it typically take them to get off their back. And as a reminder, ApneaGuard starts out, night shift starts out at the lowest vibration. It vibrates 6 times. If the patient isn't off their back, we bump it up slightly and it goes for 6 times. And then again, 6 more and 6 more and so on until it hits the maximum. And then we start really randomizing the vibration from there. So what we see is it's one of those things that most patients, it takes them to the very beginning of the 3rd vibration level, and that's when they get off their back. With the chest belt, though, we do not present the sleep wake because that was developed based on it being worn on the neck where there wasn't a lot of movement, and because this is actigraphy based, and just the movement of the chest wall really scrambles the algorithms for this. So if you do look at, or you do get outputs of the night shift from the chest mode, you'll still get the position and you'll still get the acoustic microphone. You will not get the sleep wake. Also, with the next generation of the device is just now, I believe we shipped our first ones on Friday. We've added a Bluetooth. And so there's a mobile app now for patients. And this was really, there were a lot of requests coming out of Europe, for example, in the Netherlands, where there is reimbursement for position therapy, but they need to monitor compliance. So what we've set up now is in the mobile app, the patients can type in an alternative email address. And so when they go to generate their report, they can automatically email it and transmit it to your email address at your company. And you can see all of these detailed reports. And the bundle of reports that we send out includes 90-day compliance as well. So we believe that this, while it's going to be a little bit more expensive, and actually for the resellers in Canada, part of the benefit of the exchange rate and part of the pricing is it has not gone up that much, with the benefit of being able to go on the chest and now having a mobile app. I don't know if anybody's ever explained to you about our positional sleep assessment system. This was something that we started developing. I think it's been cleared now and available in Health Canada for at least 2 years, maybe 3. But this was something we saw that the controversy about dentists doing home sleep apnea testing, and many of them were just saying, this is too expensive, I'm just going to use an oximeter. But they really, as we're trying to encourage them to look at the positional influence on their oral appliance therapies, what we wanted to do is provide a way to help them use their oximeter and get positional information. So what our software does is it allows the clock in the Nonin wrist docs to be synchronized with the night shift, and then we can get a report that gives either a 3% or a 4% ODI. And a couple of years ago, I published a paper where what I was interested in is, if we're going to use the ODI, how close is it to a level 3 device? And what we found was there's some noise. The ODI sometimes is greater, sometimes it's less than an AHI when it's less than 10. But when you have an AHI that's 10 or greater, the ODI is highly, highly correlated and is as useful of a measure in being able to look at positional OSA and outcomes. And we do make this software, it's a free license for night shift resellers, which you folks are. So if you didn't know about this, we'll be glad to talk about this next week. And then finally, one of the areas that I'm very passionate about is this combination therapy approach. So what we did with the POSIS software was to provide a way of being able to combine the oral appliance with the position therapy and being able to say, what's the best approach for this patient? So we start out with either the apnea guard or the patient's custom appliance, and we can do a 3-night assessment. And the software provides for this. And the idea is all 3 nights you're going to wear the oximeter. All 3 nights you're going to wear the night shift. Now, the first night, the night shift is not going to vibrate, and we're going to get a baseline. On the second night, the night shift again will not vibrate, but the patient's instructed to wear their oral appliance. So this is going to allow us to be able to get an oral appliance therapy efficacy study. And on the third night, then the night shift will begin to vibrate, and now we'll be able to see how well that combination therapy does. And we've gone through and analyzed our data, again, using the non-supine AHI as a surrogate for position therapy, going back to the data I showed you earlier that shows that the non-supine AHI is really quite stable. That what we found in this data set was that 41% of the time the oral appliance worked on its own, didn't need anything else. About 25% of the time, there would be an optimal outcome if position therapy was combined with the oral appliance. So here we're talking about 66% of the patients. But we also found 14% of the patients did not respond to the oral appliance, but had POSA and would have done very, very well just staying off their back. So here's about 35% of the patients. And we then had 20% of the patients who were left that, depending on how reluctant they were to go back to CPAP, the benefit of even the combination of these two, I'll call it marginal. Now, it's better than no therapy if we're moving them from severe to moderate, still may be of benefit, but looking at conventional numbers of efficacy didn't typically hit those. So with the POSA software, we identified a custom report that's able to compare the results across the 3 nights. And it's really pretty simple. You look at what the % reduction was with the oral appliance. You look again at the reduction when you combine the 2 therapies. And here, by way of example, they got a small further reduction, but not enough of one to warrant the combination therapy. And you're seeing that the combination would just move them from a 9 to a 7. This 22% isn't really even meaningful. Now, and that's phenotype number 1. Phenotype number 2 is they got a very nice response with the oral appliance. They went from 29 down to 11. But if we kept them off their back, there would be a further significant reduction, and we could get them from 11 down into the normal range. That's phenotype number 2. Phenotype number 3, they didn't respond very well to the oral appliance, but boy, if you kept them off their back, they were going to get a great response. And that's phenotype number 3. And then this is phenotype number 4 that I was alluding to. And again, it's what we're saying is they're phenotype number 4, meaning they didn't respond well to the oral appliance. They didn't respond well to the combination therapy. You could argue that taking them down from 55 to 30, is an important reduction. But that, again, is something that clinician really should be doing in conjunction with the patient and being able to negotiate what's the best use of their resource dollars, especially if it's a self-pay situation. And finally, I want to thank the colleagues of mine who work at all of these institutions who are co-authors on these papers. And for more information, you know where we are, advancedbrainmonitoring.com.